Welcome to the deep dive. Today we're getting into something really vital in kidney care, tunneled hemodialysis catheters, TDCs for short.
That's right. These are lifelines, really, for patients with end-stage renal disease who need dialysis, like now often while they're waiting for a permanent access, like a fistula or graft.
Or sometimes if that permanent access just isn't possible for them. And, the numbers are quite striking. Something like over 80% of patients actually start hemodialysis with a catheter.
It's a huge percentage, and it's important to distinguish them from the acute catheters you might see more in, say, an ICU setting.
Right, those are different.
Yeah, the acute ones are more temporary. They don't have that subcutaneous cuff, which, well, it means a higher risk of infection, and they can slip out more easily, really for short-term use.
Okay, so we're focusing on the TDCs today, the longer-term option.
Exactly, the tunneled ones.
What's the key difference there, and why are they so essential when someone needs dialysis longer term, but maybe isn't quite ready for a fistula or graft?
The big thing is that cuff. It's placed under the skin near where the catheter comes out. And tissue actually grows into this cuff. It does two things. Anchors the catheter really well, and crucially, it creates a physical barrier. Helps stop bacteria from tracking down the tunnel into the bloodstream.
Okay, like a seal almost?
Pretty much, and that allows for much longer use compared to the non-cuffed acute type.
That makes perfect sense. So look, everyone agrees AV fistulas and grafts are generally the best for the long haul, right?
Oh, absolutely, the gold standard.
But clearly, TDCs fill a critical gap.
Yeah.
What are the main advantages they bring to the table?
Well, several things. First, immediate use. You put it in, you can use it for dialysis straight away. No waiting for it to mature like an AV access.
That's huge for someone needing urgent treatment.
Definitely. Also, it's a needle-free connection to the machine. That's a big plus for many patients. You avoid repeated needle sticks, which can cause their own problems over time, like bruising or infiltration.
Yeah, I can imagine.
And the insertion itself, while it needs expertise, is generally quite direct compared to creating a surgical fistula.
Okay, let's dive into the design then. What are the engineers and doctors trying to achieve when they design these things?
Two primary goals, really. First, you need good blood flow. We're talking ideally somewhere around 300 to 350 milliliters per minute passing through the dialysis machine. That's essential for effective cleaning.
Okay, high flow. What's the second goal?
Minimizing recirculation.
Recirculation, explain that.
Okay, so you have two lumens, right? An arterial lumen pulls blood out to the dialysis machine, and a venous lumen returns the clean blood back to the patient.
Got it.
Recirculation is when some of that freshly clean blood coming back through the venous lumen gets immediately sucked back into the arterial lumen, going back to the machine without circulating through the body first.
So it's like cleaning the same blood twice instead of getting the dirty blood. Reduces efficiency.
Exactly. It makes the dialysis less effective because you're not clearing waste products from the whole bloodstream as efficiently.
So how did the designs try to prevent that?
Well, there are sort of four main design categories aimed at getting that high flow and keeping recirculation low.
Okay, what are they?
First, you've got the split tip design. It's a double lumen catheter, one body, but right at the very end, the tip splits into two separate ends. They often have side holes, too, to help with flow.
Physically separating the outflow and inflow points.
That's the idea. Then there's the step tip, or sometimes called a staggered tip. Again, double lumen, single body. But here, the venous limb returning blood is longer than the arterial limb drawing blood out, usually by at least 2.5 centimeters.
So creating distance between the 2 points, again, just in a different way.
Precisely, spacing them out. The third type is, well, pretty straightforward. The dual catheter design. You literally insert two separate single lumen catheters, often in slightly different spots.
Okay, two distinct catheters. And the last one?
The symmetric tip. Here, the arterial and venous limbs, or tips, are the same length.
Wow, quite a few different approaches. Has one of these designs emerged as the clear winner? Like, is there a best one?
You know, that's the interesting part. Lots of studies have looked at this, comparing flow rates, recirculation percentages, how long they stay open and working, which we call patency, and no single design has consistently come out on top across the board. One might be slightly better for flow in one study, another might show less recirculation in a different setup, but then maybe not have great patency.
Huh. So it's not as simple as just pick design X.
Not at all. A big review actually looked at all the research and concluded there wasn't really a definitive winner. It kind of points towards the fact that choosing a TDC isn't just about the catheter design itself. It's more about tailoring the choice to the individual patient, their specific veins, their needs.
So physician experience and patient anatomy play a big role.
A huge role. Which leads us nicely into the next crucial step. The preoperative evaluation, before you even think about putting one in.
Right. You can't just grab one and go. What does that involve?
It starts with a really thorough history and physical exam. Super important.
What are you looking for specifically?
We need to know everything. Previous central lines, any AV fistulas or grafts attempted before, any history of infections with catheters they've had, bleeding disorders, do they have a pacemaker? All of that matters.
Building that vascular roadmap, essentially, and the physical exam.
We're looking very closely for any signs that might hint at blockages or narrowing in those big central veins, what we call central veno-occlusive disease.
Like what kind of signs?
Evidence of old catheter sites, maybe swelling in one arm or the face. Sometimes you can see prominent, bulging veins on the chest or neck. Those are collateral veins trying to find a detour around a blockage.
You mentioned coordinating care earlier. That sounds critical here, right? Between the person putting in the TDC and whoever might do a permanent access later.
Absolutely vital. Think about it. You've only got a limited number of good spots to put these things, both temporary and permanent.
Right. You don't want to burn bridges, so to speak.
Exactly. So having the same team, or at least a really well-coordinated plan, helps preserve those precious access sites for the long term.
Okay. History and physical. Check. What about imaging before the procedure?
Yeah, preoperative imaging is really valuable. Helps us see if the target veins are open and spot any potential roadblocks before we start.
What's the first step usually?
Often, it's color flow venous duplex imaging. It's basically an ultrasound. Non-invasive, easy to do, great for checking out the jugular veins in the neck and the axillary veins near the shoulder.
But limitations.
Yeah, it struggles to see deep into the chest. The lungs and bones get in the way, making it hard to visualize those really central veins like the superior vena cava.
So if you need a better look centrally,
Then we move to more advanced stuff. Magnetic resonance phonography, or MRV, is one option. It's very good at finding blockages or narrowings in those central veins.
any issues with MRV?
Well, the contrast agent, gadolinium, can be a problem for patients with really poor kidney function GFR below 30. There's a rare but serious risk of something called nephrogenic systemic fibrosis.
Oof. Okay. Is there an alternative?
Yes, thankfully. There's an iron-based agent called ferromoxitol that can be used for MRV instead. It avoids that risk and still gives us good images.
Good to know. Other imaging options.
Computed tomographic phonography, or CTV, that's another cross-sectional imaging technique.
Advantages of CTV.
It's often widely available, it's fast, and there are generally fewer concerns about the contrast agent compared to gadolinium, though contrast is still used. It gives excellent views, especially of the superior vena cava, and studies show it matches up well with the gold standard for finding central blockages.
And what is that gold standard? You mentioned it.
That would be catheter-based contrast phonography.
So actually putting a catheter in and injecting dye, when is that done preoperatively?
It's usually reserved for cases where we strongly suspect a significant blockage based on the history, exam, or the other imaging. The big advantage is if we find a narrowing during the venogram, we can often treat it right then and there, maybe with balloon angioplasty or a stent.
Ah, diagnostic and potentially therapeutic in one go.
Exactly. Plus, it often uses less contrast dye overall than a CTV, which is a bonus for the kidneys.
Okay, evaluation complete. We know the patient's anatomy. Time for insertion. Where's the preferred spot to put these TDCs?
Generally, the right internal jugular vein, the right IJ, is the go-to site.
Why the right side specifically?
It offers a shorter, straighter path down to the right atrium of the heart. Less kinking, potentially better flow, and studies show these catheters tend to last longer compared to left IJ placements.
And definitely better than the femoral vein in the leg.
Oh yeah, femoral catheters tend to have the shortest lifespan. And we really try to avoid the subclavian vein under the collarbone.
Why avoid the subclavian?
Because putting a catheter there has a higher risk of causing stenosis or narrowing of that vein down the line, and that can totally mess up your chances of placing a good permanent fistula or graft in that arm later. It's all about preserving future access options.
Makes sense. Thinking long term. Does the catheter length vary depending on the site?
Absolutely. For a right IJ, you're typically looking at 19 centimeters or often 23 centimeters from tip to cuff. Left IJ needs to be a bit longer because the path is more angled.
And femoral.
Much longer. You need catheters over 40 centimeters to get the tip up into the inferior vena cava properly for good flow. The length is crucial for getting that tip placement just right.
Okay, site and length decided. Walk us through the actual insertion procedure. Sounds like it needs precision.
It absolutely does, and it should always be done in a proper procedure room under fluoroscopic guidance.
For us, maybe that's the real-time X-ray. Why is that so critical?
Several reasons. One, many patients already have some underlying vein issues, blockages, or narrow-ins that make just blindly sticking a wire in dangerous. Fluoroscopy lets us see the wire's path.
Okay.
Two, we use stiff dilators and sheaths to make the track for the catheter. Under fluoro, we can see if the wire is kinking or if we're pushing too hard against the vein wall, which could cause damage.
Prevent injuries.
Exactly. And finally, at the end, we use it to confirm the catheter tip is perfectly positioned, usually in the right atrium, and that there are no kinks in the catheter itself. Bedside placement. Really strongly discouraged. You need sterility, the imaging, and potentially the ability to intervene immediately if something goes wrong.
Got it. Fluoroscopy is non-negotiable.
Yeah.
What about anesthesia and prepping the patient?
Usually, local anesthetic numbs the skin, plus some conscious sedation keeps the patient comfortable but awake enough to cooperate if needed. We also give antibiotics beforehand, prophylactically, mainly targeting gram-positive bacteria to reduce infection risk.
Hence skin prep.
Meticulous cleaning, isopropyl alcohol, chlorhexidine solution, standard sterile procedure.
Then comes the actual needle stick.
Right. We use ultrasound guidance, again, very important, confirms the vein is open right where we plan to stick, and guides the needle precisely. Usually aim about 2 to 3 centimeters above the collarbone for the IJ.
Do you use a big needle?
Often we start with a micropuncture technique. It uses a tiny 21-gauge needle and a very thin 0.018-inch wire. Less risk of hitting the artery by mistake. Once we're in the vein with that, we swap the thin wire for a standard 0.035-inch guide wire. Then a small incision at the wire entry site.
And you're watching all this on the X-ray screen?
Constantly watching the wire's movement under fluoroscopy, making sure it goes down towards the heart smoothly.
Okay, wires in place. How does the fairly bulky TDC get in?
Well, sometimes you need a bit of firm, steady pressure, especially if there's scar tissue. The key is ensuring that guide wire travels down the superior vena cava, ideally into the inferior vena cava, without going into the heart chambers themselves.
Why is avoiding the heart chambers so important?
Particularly with left-sided access, the path is more tortuous. If the wire loops inside the heart, the stiff dilator following it could potentially perforate the heart or a major vessel. Using a stiffer wire than the one in the basic kit and watching very carefully under fluoro as the dilators and sheath go in helps prevent that.
Sounds like a critical point. Now, the catheter itself needs to tunnel under the skin, right? Exits somewhere else.
Correct. That's the tunneled part. Two main ways to do it. Antegrade or retrograde.
Antegrade.
With antegrade, you make the exit site incision first, usually on the upper chest, sort of down and out from the neck entry point. You figure out where it should be by laying the catheter on the skin.
Okay.
Then you attach a tunneling device to the catheter and pass it under the skin from the chest exit site up to the neck incision. The cuff needs to sit about 1.5 to 2 centimeters inside the tunnel, away from the exit site, and deep enough not to poke through the skin later.
Tunnel created. Then what?
Then back at the neck site, you dilate the vein entry point, insert the peel-away sheath introducer unit, take out the inner dilator and wire, and feed the TDC through the sheath into the vein. Once it's in position, you split and peel the sheath away.
Wow, quite the subcutaneous journey. What's retrograde placement then?
Retrograde is kind of the reverse order for the tunneling. The catheter, without the end ports attached yet, goes into the vein first at the neck site. Then it's tunneled down from the neck to the chest exit site. The connection ports are attached after it's tunneled.
Advantage of doing it that way.
Allows for really precise placement of the catheter tip inside the heart before you commit to the tunnel length.
Interesting. What if the usual neck veins just aren't usable? All blocked up?
Yeah, that happens, unfortunately. When conventional sites are exhausted, we have to get creative. Unconventional sites like translumbar or transhepatic access might be considered.
Translumbar. Transhepatic.
Yeah.
Through the back and liver.
Pretty much. Translumbar involves accessing the inferior vena cava, the big vein in the abdomen, usually from the back, near the hip bone, tunneling to the side of the abdomen. Transhepatic means going through the liver to access a hepatic vein, usually entering between the ribs on the side and tunneling to the chest.
Those sound significantly more complex.
They are definitely reserved for when other options are gone.
And how do those catheters fare long term?
They can be lifesavers, but generally their lifespan is shorter than IJ catheters. They also tend to need more interventions, adjustments, exchanges due to clots, migration, or infection. Exchange a translumbar one can be particularly tough because of scarring in that retroperitoneal space.
Okay, let's move to right after the procedure. Perioperative care and dealing with immediate problems.
Right. The main focus immediately after is watching for and managing any acute complications. The overall risk isn't huge, maybe around 7% reported for central lines in general, but you need to be ready. Failure to place the line and hitting an artery are common issues, followed by things like pneumothorax.
What's key to handling those?
Vigilance, recognizing a problem quickly and acting fast.
Okay, let's break some down. Pneumothorax, air in the chest cavity. How do you spot and treat that?
We always get an upright chest x-ray after placement, confirms tip position, and checks for pneumothorax. If someone suddenly gets short of breath, chest pain looks distressed, they need a chest tube put in right away to let the air out, plus oxygen.
What if it's small?
If it's small and the patient feels okay, oxygen levels are fine, we might just monitor with repeat x-rays. But if it gets worse or symptoms appear, they get a chest tube. Often a small pigtail catheter works well and is better tolerated.
And hemothorax.
Yeah.
Blood in the chest.
Yeah, that can happen if the needle, or more likely the dilator or sheath, nicks the back wall of the vein or an artery and also punctures the chest lining. Subclavian, innominate vein, even the SVC can be involved.
And they can bleed a lot.
Yes, because you can't put pressure on it easily inside the chest, and breathing actually pulls more blood in. Signs are breathing trouble, dullness when tapping the chest, maybe a drop in blood count. X-ray shows fluid.
Treatment?
Tuberotomy again to drain the blood. Rarely, surgery or using a covered stent might be needed to stop the source of bleeding.
Wire embolism. Losing the guide wire inside the patient sounds bad.
It can be. Can happen if you lose grip or if the needle shears off part of the wire, especially those thin micropuncture wires if you pull back hard against the metal needle.
What do you do?
If you feel resistance pulling the wire out, stop. Use fluoro. Maybe pull needle and wire out together. If a piece breaks off, it usually needs retrieval with a snare device in the angio suite.
What about the heart? Any immediate cardiac risks?
Arrhythmias, irregular heartbeats are rare. Usually just the wire tip irritating the heart muscle. Using marked wires and fluoro helps keep the wire out of the ventricle. If it happens after placement, check the catheter tip position on X-ray. Pull it back a bit if it's too deep near the tricuspid valve. Very rarely needs meds or cardioversion.
And the scariest one, cardiac perforation.
Very unlikely with today's soft catheters, but possible with the stiff wires or dilators. If it happens, you can get cardiac tamponade blood filling the sac around the heart, squeezing it.
How would that present?
Rapid shock, patient looks blue, neck veins bulging, fast heart rate, muffled heart sounds. Chest x-ray shows a big globular heart.
Emergency treatment.
Absolutely. Remove everything from the catheter lumen immediately. Drain the fluid around the heart, pericardiocentesis, or a surgical window. If it keeps happening, open heart surgery might be needed for repair.
Nerves. Any risk to nerves during insertion?
The brachial plexus, the big nerve bundle for the arm, is most vulnerable near the subclavian vessels. If the patient gets sudden arm pain along a nerve path during insertion, you have to pull back immediately. Permanent damage is rare, though.
Other nerves.
Vagus, recurrent laryngeal, phrenic are near the IJ. Hoarseness could mean vagus or recurrent laryngeal injury. Phrenic nerve injury often causes no symptoms. Just see one side of the diaphragm is high on X-ray. There are even super rare reports of Horner syndrome from trauma near the IJ.
Lastly, what if the catheter just ends up in the wrong place?
Misplacement. Yeah, it happens maybe 3% or so in some studies, tip in the wrong vein or even the ventricle. Fluoroscopy should prevent this. If unsure, inject contrast to check.
What if it's in the wrong vein, like the subclavian or hepatic vein?
Can injure the vein lining, cause clots. A stiff catheter pressing on the wall could even erode through, causing bleeding. Fluoro helps get the length right and spot kinks.
And if it accidentally goes into an artery, carotid or subclavian?
More likely if the patient's blood pressure is very low, so you don't get that bright red pulsing blood back. Rare with elective placements. If suspected, check pressure or blood gas. If caught immediately, maybe just pressure after removal, but often needs surgical repair because the sheath makes a big hole. If found later, definitely needs surgery. Subclavian artery injuries are tough to compress. Watch for hemothorax.
Okay, that's a lot to watch for immediately after. Let's talk long-term. How are these managed and what late complications pop up?
Long-term care is mostly the dialysis unit's responsibility. Vascular surgeons usually step in for the later, trickier problems.
Like what?
Well, one rare but serious one is air embolism. Can happen late, too.
How can it happen later?
Air gets in maybe before tubing is connected, or if it disconnects, or through tiny cracks in the catheter hub, or even through the skin tract after removal if it hasn't sealed.
So patient education is key.
Crucial. Teach them to immediately clamp or cover any open catheter end and get help. We put occlusive dressings on after removal, too. If someone collapses suddenly, suspect air embolism.
What's the immediate management for air embolism?
Clamp the catheter. Position the patient head down, left side down. The Durant maneuver tries to trap air away from the lung artery outflow. Sometimes you can even try to aspirate the air with the catheter.
Catheter occlusion blockages. You said that's common.
Very common. Maybe 30–40% get some degree of occlusion. Usually it's a fibrin sheath, kind of a sock of clot material forming over the tip.
Early warning sign.
Often it's difficulty drawing blood back, even if you can still flush fluid in. That usually means trouble's brewing.
Can you prevent these clots?
Routine blood thinners like low-dose warfarin haven't really panned out. Higher doses work better, but increase bleeding risk too much for routine use. And studies comparing different locking solutions, heparin, citrate, clot busters like alteplase, antibiotics, ethanol, haven't found one that's clearly superior for keeping catheters open long-term.
So what do you do when it does get blocked?
Often, the first step is trying a fibrinolytic agent, like alteplase. Instill it into the blocked lumen, let it sit for a couple of hours, then try to flush. Can repeat if needed. Often works, at least for a while.
Only temporary sometimes.
Yeah, might only buy you a few more dialysis sessions before it clogs again. Other options are mechanically stripping the fibrin sheath with a snare from another access point, or doing a catheter exchange over a wire, maybe ballooning the sheath first. But reviews suggest these complex maneuvers don't necessarily keep the catheter working longer than just a simple exchange.
So often just replacing the catheter is the answer.
Frequently, yes. If it's not infected, you can sometimes replace it over a wire through the same tunnel, which is less invasive than starting all over at a new site.
What about clots forming in the veins themselves? Central venous thrombosis.
Also fairly common, maybe in 30% of patients with central lines, but often asymptomatic. Less than half cause problems. Pulmonary embolism from these isn't that common, rarely fatal in this context.
Any link with infection?
Strong link. If a patient has certain bloodstream infections like Staph aureus, there's a very high chance they also have a thrombus in the vein.
How do you manage these clots?
Suspect it with arm, neck, face swelling, prominent veins, maybe unexplained fever. Ultrasound usually diagnoses it. Treatment is anticoagulation, elevating the arm. Ideally, remove the catheter if possible, but if it's the only access, anticoagulation with the catheter in place is considered.
In central venous stenosis, the vein narrowing. We touched on that risk with subclavian lines.
Right. It's from chronic irritation by the catheter. Definitely higher risk with subclavian access. Avoid it if you can.
How does stenosis present?
Can be silent. Often shows up dramatically when an AV fistula is created in that arm. The arm swells up quickly. Can cause facial swelling if it's higher up. Other signs? Dilated veins, access clotting, poor dialysis, prolonged bleeding after needles come out.
Treatment for stenosis.
Angioplasty, often with stenting, is the preferred approach. But keeping them open long-term is tough. Primary patency rates aren't great, meaning they often narrow down again quickly. Requires repeat procedures usually.
Okay, the big one. Infections. Catheter-related infections.
Huge concern. We break them down. Exit site infections, just redness stapes around the skin opening, tunnel infections, inflammation along the subcutaneous path, and bacteremia, bloodstream infection linked to the catheter.
How common is bloodstream infection?
Incidence varies, maybe 0.6 to 6.5 episodes per 1,000 catheter days. Can lead to really serious stuff like endocarditis or abscesses elsewhere, especially if you try to salvage an infected catheter.
How do you treat these infections? It sounds like it depends.
Highly individualized. Options range from guide wire exchange, removal, and delayed replacement, trying to salvage with antibiotics and maybe antibiotic locks instilled in the catheter, especially if it's the last access.
What bugs are common?
Mostly gram-positives. Staph aureus is a big one. Start with broad antibiotics, then tailor to the culture results. Fungal infections need specific antifungals.
How long is treatment?
Depends on the bug and severity. Uncomplicated Staph aureus bacteremia might be 4–6 weeks. Gram-negatives maybe 7-14 days. Candida at least 2 weeks.
Mm.
Complicated infections like endocarditis or bone infection need much longer courses, 6-8 weeks sometimes.
When do you absolutely have to take the catheter out?
Simple exit site infections might resolve with just antibiotics, but definitely remove it immediately if the patient's unstable, if fever, bacteremia persists despite antibiotics after 48-72 hours, if there's metastatic infection, if it's certain bugs like Staph aureus, Pseudomonas fungi, or if the tunnel is clearly infected.
What about antibiotic locks or guide wire exchange? Do they help avoid removal?
Studies suggest antibiotic locks, sometimes combined with exchange, can have good cure rates for some infections, better than systemic antibiotics alone, especially for bugs like coagulus-negative staph. Less successful for Staph aureus.
Finally, getting the catheter out when it's done its job or causing problems, usually easy.
Usually straightforward. Local anesthetic, dissect the cuff free, it slides out. But
Wow.
rarely, especially with old subclavian catheters, they can fracture during removal, often near the collarbone where there's stress. The broken piece can embolize, needs retrieval with a snare.
Anything else make removal tricky?
Yes, that fibrin sheath again. If a catheter's been in a long time, the sheath can get really thick and adherent, basically tethering the catheter in place even after the cuff is loose. Need special techniques than maybe sliding a bigger sheath over it using a laser sheath or inflating balloons inside the catheter to break the sheath free.
Wow. This has been an incredibly detailed look at tunneled hemodialysis catheters. Really comprehensive.
They're complex devices with a lot of nuances.
Yeah, just to recap the big points for everyone listening, we covered why TDCs are so necessary, the different designs trying to balance flow and recirculation, the crucial steps in evaluation and insertion, especially that imaging and fluoroscopy.
Absolutely essential.
And then navigating that whole range of potential complications, both immediate ones like pneumothorax or misplacement, and the long-term issues like occlusion, thrombosis, stenosis, and of course infection, plus how we manage all of that.
Understanding all these pieces is just vital for anyone caring for dialysis patients.
No question. It really impacts patient outcomes and their quality of life.
Definitely.
So it leaves me thinking, as we look ahead, with advances in vascular access, maybe better infection control strategies, what does the future hold for temporary dialysis access? Could we perhaps see a shift away from catheters being the main starting point for so many patients down the line?
That's a fascinating question. The drive is certainly always towards getting better, more durable, less complication-prone access. It's something the field is constantly working on.
Food for thought, definitely. Thanks so much for sharing all this insight today. It's been a real deep dive.